So it's my great pleasure today to introduce Dr. Jay Shaw, a health services researcher at the Women's College Hospital Institute for Health System Solutions and Virtual Care.
Mouthful.
And thankfully, there's an acronym for that, WEAVE. And he's a postdoctoral fellow at the U of T in the Health Policy Management and Evaluation program. He trained as a physiotherapist before doing a PhD at Western University and focused on community-based healthcare. Completed that in 2012 and is currently working on a number of health services and policy research projects supporting WEAVE's consultations to the Ministry of Health and Long-Term Care. So today he's going to be discussing his CIHR-funded postdoctoral research on the impact of policy on transitions from hospital to home for older people in the English National Health Service, and bringing together the literature on policy implementation and implementation science. Thank you very much, Jay.
Thank you, Robin. Okay, so you'll have to bear with me because I'm coming down with a bit of a cold, so forgive the raspiness and the frequent drinking of water, which I'm sure I will do throughout. And so today I'm going to talk about the general topic of how policy shapes practice and why I think that's important in implementation science. And I'll also be talking about a couple of specific research projects. And I'll look forward to some good kind of discussion and your questions and feedback afterwards. I find implementation science to be a really kind of wonderful and interesting field. I think in large part because it brings together so many interdisciplinary perspectives. And from my own perspective, understanding implementation kind of fundamentally means understanding why people do what they do. So why do people behave in particular ways when delivering healthcare? And how can kind of routines and habits of practice be changed to promote more evidence-based, person-centered care? And I think a lot of those questions fall pretty squarely in the wheelhouse of social science. And so that's the kind of perspective that I bring to my work in implementation science. So that's really what I'll be addressing today. So just for a bit of an outline, first I'm going to talk about some uses of qualitative research. And this is really basic, just a kind of general overview of a couple of methodologies to provide some context for my discussion of case study research, which is what I will really be talking about today. Then I'll talk about some ways of thinking about policy contexts. Obviously, it's a complex issue, so I think it's important to provide some kind of signposts for how we can think about it. Then I'll talk about a case study of transitions from hospital to home, and that's in the English National Health Service, which was my postdoc research. And then I will kind of summarize some lessons learned so far, repeat some of the things we addressed, and then just provide some kind of final thoughts on a current project and hopefully have some discussion after. So I think I should be talking for kind of about 40 minutes. So on to some uses of qualitative research. So qualitative methods have been used in many, many different ways in healthcare over the past kind of 40 or 50 years. And I'm just going to suggest some of the research questions that some popular methodologies kind of tend to be used to answer. The point isn't to be comprehensive and thorough, but as I said, just to provide some context for case study research, which I'll primarily be talking about. So for those of you who know about qualitative research, this is certainly going to seem overly simplistic, but in an interdisciplinary field like implementation science, I tend to think simple is best. So one of the more popular methodologies in qualitative health research is called phenomenology. And that's often used to answer questions like, what is the meaning of this person's experience? Or what does the experience for this patient with this particular condition, what does that mean to them at this particular time? And those questions represent a strong mandate of a lot of qualitative health research to encourage you to take somebody else's perspective, even if that's just for a moment. So it's not about generalizability in a sort of more traditional research sense, but about personal reflection and encouraging empathy. So another popular kind of qualitative research is called grounded theory, and it's often used to study process. So for example, what's the process of learning to self-manage a chronic condition? Or how does somebody recover from depression? So those questions refer to steps that people go through when engaging in a health-related journey over time. And the findings of grounded theory studies tend to be viewed actually as quite helpful, practical for healthcare providers. A third kind of qualitative research, this one's growing in popularity, which I think is great. It's called community-based participatory research or participatory action research. And this kind of qualitative research doesn't actually even pose like an a priori research question. Instead, it engages particular communities to ask and answer research questions that are important to them. So, for example, if there's a community that has seen a lot of gun violence, a researcher would approach representatives from that community and ask, what's important to this community? What would you like to see changed in this community? And then the researcher would support those representatives of that community as they answer research questions. So that methodology is as much about action as it is about learning and research. So as I said, I outlined these ways of thinking about qualitative research to set up my discussion of case studies. And I think case studies are unique amongst these and other ways of doing qualitative research, in part because case studies are considered quite flexible. Many people are familiar with case studies because they appear in a lot of different disciplines. You'll have clinical case studies, business case studies, policy case studies, etc. And the research question that I think case studies are so well suited for, and I think have really helped to drive their popularity across disciplines, is something like this. What is really going on here? So the case study encourages researchers to peel back layers of what seems obvious, to look beneath the surface presentation of a clinical case or an organization or a policy or whatever. It encourages researchers to use whatever methods and theories necessary to produce the strongest possible explanation for what's going on. So when we look at the process of implementation, whether that's of a policy, a model of care, a best practice guideline, or whatever, understanding what's really going on during implementation seems fundamental to getting it right. I doubt many people would disagree with me on that, but we can discuss that afterward. So I'll elaborate on why I think that's so important, and I'm going to start by talking a bit more about policy and policy contexts. So the philosopher of science Andrew Pickering published a book in 1995 called The Mangle of Practice, and it strikes me that somebody should write a book called The Mangle of Policy, because when we look at the effects of any one individual policy, we really have to look at how it gets mangled by all the other policies already influencing human behavior. So it's that mangle that really composes the kind of policy context that I'm going to talk about today. So I think understanding the role of policy context in implementation science requires an understanding about policy and its implementation, so we'll begin with some definitions. Policy is most often understood as something that governments make and do, and Van de Leuve et al. Explain, policy is in itself a fuzzy concept, variably apprehended as the actions of government and the intentions that determine those actions, or rather anything a government chooses to do or not to do. So that's an important way of understanding policy, and I think it resonates with the way we tend to understand policy in healthcare. But I think it's important to note that not all policy is government policy. Nilsson et al. In a great paper, they explain that it's important to differentiate big P policies in the form of formal laws, rules, and regulations from small p healthcare policies, such as guidelines and management decisions that affect clinical practice. And we can think of organizational policies we all have to follow, right? If you just think about the human resources onboarding process, there's lots of rules and procedures to be followed. So policy is the official stipulations of the Ministry of Health and Long-Term Care, and it also is the rules of the organizations we work for. But it's also the management decisions that affect our everyday work. So in that way, policy can be considered to capture the kind of high-level arrangements that structure the health system, the formal rules of the organizations we work for, and also the informal rules and decisions that sort of most immediately affect our everyday lives. So let's think of an example here. So consider all the policies that have already shaped your day today, just in terms of how you arrived at work this morning. So first you have formal government policies, and these are present in our everyday lives, our everyday commute in a number of ways, and they're enforced with a kind of range of punishment rules if those are broken. Then you have the organizational policies of the various organizations that might have been a part of your commute this morning. So these pertain to kind of what doors you're allowed to use and how you pay your fare and how you move through a transit station, for example. And then you have the informal policies that seem all too important and immediate, such as what your lunch looks like when you put it in the fridge. These are important things. So we've probably all obeyed all of these policies already today, maybe with a few exceptions. And looking at this, it looks like a mangle of policy. There's a lot going on there. So this is just related just in relation to your commute this morning, so you can think of the kind of mangle of policy that exists when we talk about delivering healthcare. Okay, so how does this relate to implementation science? In 2009, a group of researchers published this paper reviewing all the existing implementation and knowledge translation theories for healthcare from a range of disciplines. And I'm sure this paper will be familiar to some of you. It's been cited 1,093 times on Google Scholar since 2009, so obviously very popular. The authors created a model that looks like this. It's not exactly pretty, but it gets the point across. We have an intervention that needs to be adapted to the organization. There's an outer setting, kind of that policy context we're talking about, an inner setting, the organization, the people involved, and of course the process of implementation itself. So these are all important considerations, and it's a lot to think about. And overall, I think this is really a fantastic framework. But I have a couple of issues with the way that they discuss policy context that I'm addressing today. So I'll elaborate on that. So we would expect policy in the high-level governmental sense that I mentioned to fall under the outer setting category. And indeed, it does, so that's a good start. So under the description of outer setting, the authors include 4 things: patient needs and resources, kind of the community being served, cosmopolitanism, which really just refers to how networked the organization is with other organizations, peer pressure, which was distinct from cosmopolitanism, and then finally, external policies and incentives. So we might want to poke some holes in this list or suggest that other things be added, but for the moment, let's just focus on this last topic, external policies and incentives. So I'm going to show you everything that these authors included about external policies and incentives in their findings section. Just a brief little description of this kind of category in their findings section. So they say external policies and incentives are broad constructs that encompass external strategies to spread interventions, including policy and regulations, governmental or other central entity, external mandates, recommendations and guidelines, pay for performance, collaboratives, and public or benchmark reporting. Okay, so the authors clarify in this paper that they're really providing a list of things to consider during implementation as opposed to a kind of comprehensive explanation of how to consider them. So, based on that, I mean, this list seems kind of fine. It's pointing in some good directions. But I think it's a bit misleading where they imply that external policies and incentives should only be understood in terms of strategies to spread interventions. And I think that makes it sound like unless a particular policy is directly related to the implementation initiative you're focusing on, then maybe it doesn't need to be considered at all. Now, to be fair, I don't think that's what the authors meant here. They discuss this topic elsewhere in the paper and elaborate on it a little bit more fully. But when I read that, and I had that thought, it raised a really interesting question. And that's, how do you know which policies you're supposed to pay attention to when you're implementing a new practice? Like, where do you even start? Is it only the policies that are intended to have a direct impact on the specific area you're focusing on? Or does it include policies that might not have any apparent direct relationship to your specific implementation initiative? And that could get pretty messy. So I'm sure you all have an answer percolating to that question in your mind at the moment. But I'm going to suggest that it's a perfect scenario for us to come back to our contributions of case study methodologies. Because I would say that the answer to that question depends on what's really going on in your specific implementation initiative. That's a good example of why I think case study methodology is so important for implementation science. So just one more kind of thought about policy. So research on how policy gets implemented has taken three kind of distinct turns over the past 60 years. There's a strong history of implementation research on policy. And it's moved from a pretty simplistic kind of top-down approach to thinking about how policy gets implemented toward a more nuanced, kind of complex approach that considers the bottom-up implementation of policy, what kind of stakeholders on the ground are doing, as well as how different policy levers or instruments kind of interact with one another. The effects of each of them aren't necessarily all that clear. So this is a very classic table of policy instruments that's adapted from Christopher Hood's work in the 1980s. Sorry, it's a bit blurry. I'm happy to make the slides available to anyone after. So many policy researchers consider these different kinds of policy instruments. So these general categories are nodality or information, authority, so that's regulation, treasure, which is finance, incentives, and organization, which is the actual administration of services. And researchers these days consider these different kinds of instruments to interact with each other in unique ways, depending on the kind of the specific cultures and rationales, the specific people involved in local settings of implementation. So teasing out which policies and instruments are most important to consider and how different instruments like these might interact to influence your kind of implementation initiative, that's an important part of getting implementation right. That's what I'm going to suggest. And I'll say that there are instances where one specific policy, the instruments it uses, and the ideas it represents really requires the closest examination. Like in some cases, one policy really, that's the one you need to focus on. And that's what we found in our case study of the National Health Service. But I'll also suggest that there are many other instances where that's not the case. And I'll raise some points and some questions about that when I discuss some current work toward the end of my talk. Okay, so I'm going to move on to talk about this case study. And this was looking at transitions out of acute hospital care for older people with complex needs in the English NHS, the National Health Service. So I'm going to kind of provide some highlights of this case study because often studies like this are reported in really kind of dense reports full of theory, that kind of thing. So I'll just provide some highlights. And I did this work with Pia Kontos, who's a scientist at Toronto Rehab here in Toronto, and two researchers at Brunel University London, Wendy Martin and Christina Victor. And they've really been a fantastic team to work with. So we heard about this hospital region in London, this one, that had a very low rate of delayed discharges. And delayed discharges are sort of equivalent to alternate level of care, or ALC, here in Ontario. This is where patients are medically ready to be discharged from hospital, but there's nowhere for them to go, or they don't have the support to get there, so they kind of get stuck in the hospital. So we knew that this hospital system that we were looking at, they were working in a new model of care, which was sort of like a virtual ward. They called it a hub, a community hub model of care. And we wanted to know how that was being implemented and how it related to their apparent success. So we wanted to know what was really going on that was driving their apparent standout performance. So we did a case study. And the specific questions that we asked were, first, what is driving the success of this hospital region in helping older people transition out of hospital? And second, what are the key influences on the implementation of the community hub model of care, and how do these influences have their impact? So we kind of were thinking there's probably a relationship between these two questions, but that was something in our case study that we kind of held at a distance. We could ask that question about the relationship between these two things. We used ethnographic case study methods, and that includes observing people as they actually do the work of helping patients transition out of hospital. So we observed discharge planning meetings, those community hub meetings I mentioned. I'll say more about those in a moment, and some other kind of ad hoc observations during the transition process. We also interviewed patients, healthcare providers, and organizational leaders in the region. We looked at a few key policy documents, and we reviewed patient records to see what was being communicated in the patient's charts. So all in all, we did 65 hours of observation, 30 interviews. We reviewed 3 policy documents and 3 patient records. And then we took all of that information and we did a thematic analysis. So we looked across all these data sources, identified kind of what were the key points that were coming out across all of those data sources that really helped to explain what was going on here, to answer our research questions. And then we compared our themes with a whole range of theories that try to explain things like this. How do organizations do what they do? That explain implementation science in order to identify the best possible explanation for what was going on. So I'm happy to elaborate more on that kind of theoretical and analytic part afterward if anyone's interested, but I'm going to move on now just to present some key points about what we found. So a couple of comments about the Community Hub. No, this is not an actual picture of the Community Hub. This is from Google Images. The Hub initiative was supported by leaders across hospital and social services, and they essentially gave additional resources to support healthcare providers to get together in person once per week to discuss the transition plans for patients with kind of the most challenging needs. And the Hub was chaired by a general practitioner, but a number of leaders from the hospital, including a senior consultant physician, were really instrumental in getting it all set up. The Hub included a wide range of interprofessional healthcare providers, so nurses, physios, OTs, social work, and a psychologist. And then when needed, additional people would come. So for example, a couple of times there was a representative from social housing was there. And the Hub had been established for just under a year in 2013 when we did our field work. So when we asked participants about the Hub and the success of transitions in the region, many of them, and especially the ones who had been around for a long time, some of the organizational leaders, they pointed to the importance of this one policy called the Community Care Delayed Discharges Act, or the Delayed Discharges Act for short. And this act actually came into effect back in 2003, but it had taken a long time for its effects to be seen with practices like this new Community Hub. And I'll be explaining the kind of link. So the Delayed Discharges Act had been quite controversial in the UK, primarily because of its pretty aggressive approach to reducing delayed discharges. One of the key policy instruments that was bound up in this act was the mandate that if a patient is ready to be discharged from hospital, but social care is not ready to take them, home care is not ready to take them, then social care has to pay the hospital the cost of the hospital bed per day that the patient is delayed. So that's pretty aggressive. One important bit of context that I think helps to make that policy make a little bit more sense is that in the UK, hospitals and social care or social services are funded from completely different budgets. So when I say social care in this sense, I mean kind of most of the activities that we call home care in Ontario. So it includes personal support workers, social work is all funded primarily by social care, some nursing. So kind of that collection of home care services. And so hospital funding comes from a national healthcare budget, that's the NHS, and social care funding comes from the municipal level of government, which struck me as odd. I mean, only because I had never seen anything other than the Canadian kind of provincial funding models. So the same budget that collects garbage also provides social care. So, to exemplify what people thought about the importance of this policy, this is what a fairly senior manager at the hospital, he was a manager of hospital discharge, this is what he had to say. So data and qualitative research is text, so I apologize for the text. So pre-2003, before the act came into effect, the relationship between the NHS and social care was quite bad. It was really a blame culture. The NHS would blame social services for many issues, including delayed discharges, and social services would say it's the NHS's fault. The Delayed Discharges Act has improved the working relationship between health and social care by forcing them to work together for discharge planning. So it's not actually the fines that improve the discharge process, but just health and social care working more together. Okay, so that's interesting because one could reason that the Delayed Discharges Act would actually just cause more problems for collaboration. But that didn't happen, at least not in the case study region that we were looking at. And understanding why that is requires a closer look, a sort of deeper look at the policy, not only in terms of the different policy instruments or levers that it used, but also the ideas behind it. So the government published a document alongside this policy that was intended to serve as sort of guidance for its local implementation. And in the first few pages of that document, they really get at some of the core ideas that were foundational for the policy. So here's a quotation from that guidance document. The fines are a way of reflecting where costs are borne across the different parts of the health and social care system. It's about incentives to improve services and developing capacity in partnership across the whole of health and social care, not shifting money around. In fact, it is desirable for social service councils to act to minimize reimbursement payments. The focus should be on developing capacity in partnership with the NHS. I see Ivy smiling. I think we'll have some comments after, so that's good. So the point of the policy is to develop partnerships and improve collaboration. So that seems a bit surprising considering the whole thing about the fines, at least until we look at some of the other policy instruments that were built into this act. Ana Manzano-Santaella wrote a paper in 2010 with, I think, a great title called Disentangling the Impact of Multiple Innovations to Reduce Delayed Hospital Discharges. I guess that's a title only an academic could love, but anyway. So in that paper, she listed a number of the policy instruments that the Delayed Discharges Act had mandated, and that included things like required collaboration between the hospital and social care when making decisions about when a patient is safe to be discharged. So there were a number of kind of pretty strong collaborative ideas that were embedded in the policy as well. So the Delayed Discharges Act contained these kind of conflicting ideas. On the one hand, the fines could be used by the hospitals to coerce social care into taking more patients at a faster rate without any real adjustment on the part of the hospital. But on the other hand, they could be used as an opportunity to focus on these other kind of collaborative processes that were embedded in the Act and develop ways of better managing the transition process to prevent those delayed discharges from happening in the first place. So the question would then become what the local stakeholders would do about it. So we'll come back to the implementation of the community hub. So the local leaders who had been around since the Delayed Discharges Act was introduced back in 2003, they talked about the process of adapting the kind of ideas and mandates of the Delayed Discharges Act to fit within their local circumstances. That was a challenging process, said these leaders, where they had to build new relationships across health and social care and work on developing trust where there hadn't been any before. So I'm not going to spend, that's a really interesting story, and that creates kind of a bulk of the case study. But what I want to talk about now are the implications of that process, which is the other, I think, really important part of the case study. So the implications of that process 10 years later in 2013 for the implementation of this community hub. So the collaborative ethos that had been kind of championed by those local leaders back in 2003, that had gradually grown and spread across a wider range of stakeholders in the region. Those who had been around for a long time, like that hospital discharge manager I quoted, they recognized the debt of younger leaders to the original kind of implementation and introduction of this policy. So I want to show how the impact of the Delayed Discharges Act was present among some of these newer leaders even 10 years later. So this is a quotation from somebody at the director level at the hospital. And she had integrated care within her portfolio. She said, "I think the reason why we've been able to move so quickly is because we haven't done structural integration and we've majored massively on relationships. So when you're talking about collaboration, people come here thinking we've got some sort of secret formula. If they just apply it, they can deliver the same results as we have. But actually, the biggest single success factor I think we've had for our integrated care program is the time and investment we've made in supporting relationships among providers. So this director explicitly recognized the importance of relationships between health and social care providers, and she actively supported programs like the Hub to leverage those relationships for improved care. So this is a small p policy as management decision. That's like what Nilsson et al. Described that we quoted earlier. So she didn't develop this recognition in a vacuum, this director. She learned it from experience, from mentorship, from her community of practice, and those are all part of a policy context that has been substantially affected by the Delayed Discharges Act. So this is a key point here. The impact of this policy is not only in terms of the obvious need to report delays and enforce the fines, but more importantly, in the development of a local ethos of collaboration across health and social care. So the policy was instrumental in kicking this collaborative ethos off. And this is the tricky thing about understanding policy context. It's not necessarily as straightforward as the rules and regulations that are apparent by looking at a collection of policy instruments or policy levers. So the last bit of data that I'll show is from a healthcare provider. And this was a nursing consultant. So she had been working for 10 or 15 years as a home care nurse. She was on the social care side. And this is just to show how healthcare providers also responded to this kind of partnership ethos. They bought into it as part of their work with the Community Hub. So she said, the Hub is about sharing information, developing the relationships and the networking. Any sort of joint working that might be possible on discharge pathways and service improvement, that sort of thing. I think those forums are ideal for actually maintaining those good working relationships. And actually, I think, improving the whole sort of discharge pathway for patients, really. So this was not just something that local leaders acknowledged, but something that the healthcare providers participating in the Hub understood as well. The actions that the healthcare providers took in developing the Hub, in enacting that Hub model of care, those were fundamentally shaped by the policy context from this Delayed Discharges Act as well. So you can see how this is an example of an implementation initiative that was influenced by a very specific policy context arising from a very specific policy. And it made sense for us to focus specifically on the Delayed Discharges Act because of its kind of profound impact on this particular implementation initiative, this Community Hub model of care. But that, of course, is not always the case. And just before getting into that, I'm going to summarize some key points so far. So far we've suggested that understanding the influence of policy context might mean looking beyond government policy to see the organizational policies and management decisions that also impact implementation. Paying attention to how policy instruments interact with one another, because sometimes they act in conflict, sometimes they act together in concert. Identifying the ideas behind a policy, because sometimes those are more important than the actual policy instruments used. And exploring how a policy has become a part of organizational routines and individual mentalities. Now, this is not to say that every implementation project is going to be able to find all of these things or should pay attention to all of these things specifically. It's just to say that these could be of primary consideration depending on what exactly is going on in your implementation initiative. And that's, again, I think, justifies kind of the focus on case study research for identifying what's really going on. Sorry. So I'm going to finish up by talking about what happens when one bit of policy isn't so clear. And many implementation initiatives will take place in the context of a much wider variety of kind of relevant policies. And these are maybe ones that don't have such clear connections to the specific implementation project. It's much harder to specify how policy impacts practice in those scenarios. So let's look at the example of virtual care technologies in Ontario. And we'll use the example of a remote patient monitoring and self-management application for people living with diabetes. This is a project that a number of Weave researchers, including myself, are working on currently. So evaluating the implementation of this app for remote patient monitoring and self-management of people with diabetes in the community. So what are the potential range of policies that might be important to consider here? And we can think of some up front, and they might include the obvious billing codes. So doctors need to be able to get paid for their use of this thing. This links more broadly with physician funding models, which is a very hot topic right now. Privacy legislation, so that relates to concerns about any data transfer to and from the application. Health system structure and silos, so that relates to the general lack of interaction between specialty care and primary care. The Regulated Health Professions Act and scope of practice, who would get to link up with the application and how, which professionals would get to use the application. And healthcare procurement policies, so how would these technologies or applications even find their way into the health system in the first place? And I think a key strategy to employ in a scenario like this is to speak with and observe the people tasked with actually implementing that technology in practice. So where do they encounter barriers? Where does implementation break down? And answers to those questions provide some first clues for identifying which policies might influence the implementation process. But I think the challenging part is keeping in mind those key points we just reviewed, not expecting the impact of those policies to be available at the sort of surface level and obvious, just waiting for us to discover. I think we have to remember to ask, how do these different policies act in conflict or act together? How do they interact during the implementation of this application or the app? What ideas do these policies represent, and what do key stakeholders think about those ideas? What impact does that have? The point about privacy law, do people actually care about that? Is that important? So I imagine it's pretty clear by now that I suggest that it's only when we unpack these points, unpack the mangle of policy, that we can really understand the influence of policy contexts on this or any other implementation initiative. And that's really all I have by way of a conclusion. So I'd love to hear your questions and comments. Thank you.
Well, thank you. That really interesting talk, and I have a list of questions, but I'm happy to open the floor for other people to start. No questions from the floor? Stephen?
It's an interesting talk. If you go back to using the concept that qualitative research is tools to evaluate the impact of policies and the implementation of them, I guess it makes me a bit uncomfortable, and I haven't thought about it much before that. I like what I would say traditional or allopathic science that we do. And if there's no hypothesis to test, and if there's no formal structural way of a null hypothesis and rejecting it, it strikes me as it's very, 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 it's likely there's a foregone conclusion. I guess every single policy study like this surprisingly would support the position, largely a political position or whatever social position of the researcher going into it. In other words, it seems to me you have every qualitative research that I've read, the conclusion is foregone, that the person has a position to take. I can write a case report which supports a position for a medical intervention. I can find, if I like it, I'll find a patient that did well. If I don't like it, I'll find a patient that died. Then I'll write a little cute essay around it and then say this is a policy analysis. To me, you use case reports, you use et cetera, and then you use the quotations. To me, using the quotations of the patients is very much like I read a book recently, the Jan Martel, Hills of Portugal, and there's a bunch of reviews and it's very mixed. It's this is Life of Pi, the third guy.
Right.
And then you read the back of the book, and lo and behold, all the reviews are wonderful. To me, that's the kind of policy analysis that the marketers of, Macmillan does in order to sell the book.
So you think we're trying to sell the Delayed Discharges
I
Act?
think that's exactly what you're trying to do. Is to sell a position that you believe in, and you will not ever come to a conclusion that's contrary to your preconceived notion going in.
Hello?
Okay, so a couple of comments. Firstly, so when we do evaluation work, like on this implementation of virtual care, we're using kind of traditional allopathic approach in a pragmatic randomized controlled trial. So we're looking at effectiveness. The point of the qualitative methods is to understand how these things are happening. When we went into this case in the NHS, we didn't know that this policy was going to be important. We found that. People pointed to that. Yes, it's what they said, it's what we observed in practice, but this is the thing about producing an explanation. Producing an explanation always depends on what you as an observer already know. And I think qualitative researchers...
Not against that, but to me that's a commentary, it's not a research.
Okay, so that's about our definitions of research, I suppose.
Yeah.
But I mean, I think that's an important challenge. And at Weave, we work in this context where we're trying to collaborate very closely with policy makers, with other key stakeholders. And I think everybody has kind of different perspectives that they're bringing to work like this. And so it is important, I think, to be able to integrate all of those. But yes, I think that's an important challenge. We certainly do acknowledge the importance of pragmatic trials and looking at effectiveness. And my position and the position of a lot of researchers in organization management studies, policy studies, a number of disciplines consider case studies like this to be very important to providing explanations for how things happen.
A defense of qualitative research will take place after we finish this sentence. Yeah.
Jay, the Discharge Act would have obviously had national implications.
Right.
And so either a whole bunch of different institutions created community hubs, and this was a remarkably successful example of that, or lots of them didn't in fact create community hubs, and lots of people responded in different ways, and this was a remarkably successful example of a response.
Yeah.
So I guess I'm wondering if you can talk a little bit about whether there were hubs, whether the UK is awash with hubs, and this is just a good example of a hub, and so therefore the question is, why this one versus the other similar models, or whether in fact the model itself was a relatively unique or rare response to a national trend.
Yeah, sure. Thanks. So there wasn't like a whole slew of hubs created across the country, which I think points to the importance of like what local stakeholders do and how policies are interpreted and enacted at the local level. And there's models of care like this have been used kind of all around the world. We have a virtual ward here. And I think that the kind of factors that determine the success of those things will be unique to each scenario. And that's another reason why I think taking a close-up view of this particular one, it's not about identifying generalizable knowledge that everybody should apply the Delayed Discharges Act. It's about producing insights, important things to consider when doing a similar initiative, implementing a similar initiative elsewhere. So I think that's a really good point, and I think it's super important to emphasize that any implementation initiative, and this is shown across implementation science theories, needs to really consider what local people are doing, how they react to the implementation initiative, how it kind of is given life in local context. So it's a great point.
Yeah.
I wanted to explain why I was smiling there, because I was actually working in the Department of Health in the UK just after this. But one of the things I just wanted to comment on was that you mentioned that the money seemed to be coming from two different departments of the government. So essentially the money for social care technically came from the department that funded municipalities or city governments, I guess, and then the part that funded the NHS came from the Department of Health. However, one thing that I learned when I joined the Department of Health is that all that money actually comes from the same place, from the Department of Health, but is ring-fenced and given to local councils to administer social services locally. So actually the delayed transfers were transferring money back and forth within an envelope of health money, which I think is something that in the civil service we knew, and was partly one of the sort of sneaky things that you do when you're in government, to sort of wash money. And in the end, all the money comes from the same place, it comes from the public person, that kind of thing. So I think one of the things that people very often, and that might have been an interesting sort of addendum or case note to the stuff that you guys were doing, which is about what is the motivation, or explaining the sort of why of how that came to be in the first place, why they decided first of all, the fact that it sort of technically comes from two different places, even though it comes from the same place, and what it means to have those incentives working at that level, that sort of
Yeah,
I guess,
yeah.
higher level.
Yeah, and I think like the significant, one of the most significant points there is like, I guess technically it would be feasible to do something like that in Ontario because organizations are independently run. So wherever the money is coming from, when it's like a part of the budget of these two organizations, they have interest in keeping it there, right? So it would still stand, but thank you.
I have a question. Did I understand that there was a 9 or 10-year lag between the act being passed and the implementation of the hub? And do you have any idea of what was going on during that 10-year period in this particular region?
Yeah, of course. Good question. And I brought actually our manuscript because I figured, there's one really nice quotation from, so when the act was introduced, there was a special committee struck of kind of leaders from organizations all across healthcare, social care, and they essentially developed a local plan for the implementation of what would happen with these new fines and how they would work with them, or in this case, work around them, in order to kind of produce these trusting relationships and better collaboration. So I'll just read this one. So this was a senior director at the social care organization, social services. She said, yeah, so we were obliged to sort of toss up fines, but we got around actually taking money away from each other by getting a Section 31 agreement saying we won't fine people, but we'll pool any fines into a fund that will pay for delayed transfer process people. So they actually just agreed, okay, we're not going to pay you for delayed transfers. We're going to take that money and pay for these other employees to help prevent transfers, delayed transfers from occurring. And she continued, just a couple more sentences. Our strategy says if people need this sort of care, we will jointly fund it. You trust us, we're partners, we're not going to run off with the money, we're all spending it on the right people. So they struck those kind of collaborative relationships, and that spread into a number of years of just trying to work through your basic transfer out of hospital, and that resulted in a lot of improvement. And then they began branching out into other special programs in the region, and that included other hospitals as well. So there was a lot that went on in there. It's hard, the task of the qualitative researcher is to identify the most important points, and those are what are presented in the manuscript. But of course, the short answer is that there was a lot that was going on that led up to this particular initiative.
Yeah, I was particularly wondering about the trusting relationship piece and whether it takes 10 years to start building trusting relationships that ended up being so critical to the hub's success. So.
And that's another good point. I think that's something that's very, very idiosyncratic. In the course of doing this research, I discovered a field called interpersonal neurobiology, which addresses kind of how people develop relationships in an interdisciplinary way. And I think that's a good question unto itself.
Anyone? Yeah, Daisy?
Thank you very much for the presentation. In terms of incorporating and building, it's very complicated when you're dealing with these policy and trying to build and answer clinical questions all together at the same time. So I don't think there's like a 100% right way to do it. I think you're totally on point to say that you have to use a lot of different approaches to answer such a complicated question. I was a little wondering, because it was a financial incentive that they used as one of the levers. Was there a health economic sort of component to this study? So did you also look at, or did anybody look at sort of how the cost and money actually ended up flowing, and whether anybody saved or it ended up costing money? Because I'm thinking all these healthcare providers, have to spend time, networking or whatever. That's time when they paid for that time.
Right.
How do you protect that time?
Yeah.
To make it possible.
Right. That's a great point. We didn't have health economics expertise as part of doing this case study, but health economics studies, evaluations have been done of this policy in a longitudinal sense as well. And the one that comes to mind showed kind of no substantial difference. And I think that's in part because each region, in the UK they're split into health regions, they kind of, each one dealt with it a little bit differently, you know? So in this case, they said, well, we're not even going to worry about that. We're just going to take that money and hire a couple of new people to help out.
Yeah.
So, yeah. So, I mean, I guess the short answer is yes, there were some economic evaluations done. I don't think they found much interesting.
I think that that conversation, and I mean, Jay and I have had several conversations about this kind of outside of this talk, but that conversation is a really great example, linking the economic analysis to the work that Jay had done about why you need both the quantitative and qualitative approach to answer these questions. And I don't think we're ever going to see an implementation science evaluation that is able to answer everything. But what I find quite interesting about what Jay's presented is that, as he mentioned, you may not necessarily be directed towards a policy document or a context. You may find that that wasn't a key factor in the success of a hub or whatever you're evaluating. But it's more so being mindful of there's this non-exhaustive list of things that can influence whether or not something's successful. And you could have seen 3 different hubs and gone in to do a case study and seen completely different, or at least to a certain degree, a completely different cluster of factors that results in that success. So I think what I really enjoyed about your chat today is that policy is kind of like the elephant in the room sometimes, that people are afraid to even scratch that surface, and you made it quite accessible. You're welcome. But I also think it speaks to your point at the very beginning that what's great about implementation science is that it's so interdisciplinary, because it's impossible to expect that any one researcher or small group of researchers is going to be able to have the perspective and expertise to explore all these different things.
Yeah. Agreed.
I think you're right that just use an RCT, a pragmatic one, that's, you're washing deliberately the differences between the communities. Like you're saying, everybody's the same. That's why we randomize, right? So we can make the groups the same, but then you miss it, right?
To our point about building relationships, like why do these 2 people become friends and have beers after work after 2 weeks of knowing each other, and these 2 people, drive each other crazy? So.
I have another question about whether this particular case study is sort of like time sensitive in a way, and whether with the next generation of practitioners and collaborators working through the hub, whether the policy itself is still going to be meaningful, or whether it's going to kind of be buried in history and practice is practice. This is how we do things. So
right.
I think that there's probably some variability even in what's important, depending on when you walk in and start asking those questions.
For sure. Yeah, and that's an excellent point. And I think, what happens between being forced kind of to do something and having a subconscious predilection to practice in a particular way. So there's a sociologist, Pierre Bourdieu, who talks about habitus. These things, policies, the way that we're brought up, they become a part of the way that we live our everyday lives. So what's to say, in that process, when is it the impact of a policy context and when is it a culture? So I think that's part of the point of this talk, is that understanding policy context is not about necessarily those individual policy instruments, but how it fuses with all of those other things that influence our behavior.
So this is just kind of a half-formed thought, but you mentioned culture and relationships, and what really struck me about your presentation is how this policy wasn't designed to be a culture shift, and yet that was the effect that it had. And I think when we're thinking about culture change movements in healthcare and like how do we shift culture, we tend to be thinking about how to implement policies specifically designed to that. But this is a great example of how a policy that wasn't necessarily intended to do that, it was about shifting money around, had that effect of doing so, right? And I think you can really only get at that understanding by doing this kind of by peeling back those layers. And I think it's just a great example of the culture, the unintended culture shifts. And I was curious, did any of your participants describe it as like using those terms like culture shift or culture change? Because they talked about, the collaboration has been really great. Like I think from your first quote, they mentioned it moved from a blame culture to a more collaborative. So if you could elaborate on that, it would be really
Yeah, I mean, the concept of culture was drawn on a couple of times, and this work was being done right at the time that there was this big report released in the UK, the Francis Report, which was basically profiling why this one hospital had really failed patients and people were dying in hallways and just like really awful stuff. And they talked about the terrible culture of care. So it was kind of all over the headlines. So people talked a lot about culture, but it's interesting because there's folk understandings of culture, right? The way that we might think of culture, my family has a culture and Toronto has a culture. And then there's like kind of anthropological understandings of culture. So I think, in the social science, the analytic side, we just, looking at all these different theories, had to identify one that made the best explanation of what we saw. So we went away from culture at that point. But it certainly could be explained through that lens. So.
Well, thank you for a really interesting, very excellent presentation. Thank you.
Thank you.